Okay, so our speaker today is Dr. Billy Bennett. Dr. Bennett has a 3-year-old daughter, Cecilia, who has Phelan-McDermid syndrome. He's also a pediatric gastroenterologist, clinical informaticist, and professor of pediatrics at Indiana University School of Medicine and Riley Hospital for Children. His clinical focus is the digestive care of children with neurological disabilities and other complex medical needs. He's also an NIH-funded clinical investigator in the areas of computerized decision support, data mining of large clinical data sets, patient engagement research, and the screening and treatment of anxiety and depression in children with other subspecialty healthcare needs. So we're very excited to have Dr. Bennett here, and I am going to turn it over to him.
Okay, so Jackie, can you hear me? Did I do it right?
You're great.
Okay, so my name is Billy Bennett, and like Jackie said, my daughter Cecilia is 3 years old and was diagnosed with PMS a couple years ago. You may sort of be concerned that this presentation is mostly an advertisement for Cecilia's modeling career, and you would be correct about that. So some stuff about her, because a lot of my experience with her colors how I approach these problems in my patients. So she's a twin, and her twin brother is Silas, and he is her favorite person in the entire world. She used to call him Us, and then now she's gotten better and she can say his whole name. This is her modeling headshot. So if anybody, if we have any modeling agents in the crowd, this is the best thing to pass around. And then this is a picture of her recently when she had RSV back in January. And I show this to really push the idea that our children are vulnerable, that things that that may not be as big of a deal for other children can really hit them hard. And she was hospitalized for several days with oxygen sats in the 80s. My wife, pictured here, who is also listening, basically stayed in the hospital for 3 days without showering or seeing anybody else. And so I think it's important for us to remember, that we have to be very careful and thoughtful when we're approaching a lot of these common problems with our kids. So I want to go ahead and have you do the first poll. And this question is just to get an idea of whether or not your child has seen a gastroenterologist. And I think it's a good sense, it gives me a good sense of how much access people have to these sort of things. So I'm going to close the poll, and then the results are that about 3/4 of people have seen a gastroenterologist, which obviously I'm biased, but I think that's good because I think a lot of our kids need this subspecialty expertise for some of these problems. So the areas that I want to cover, first I want to talk some about what the current state of the research is and what we know about GI problems in PMS, and honestly it's not very much. And a warning is that topic 1 is super sciencey, so if it doesn't make a lot of sense, I apologize, but I'll do my best. And then I want to cover 5 topics that I think are really common and that I get questions a lot about in PMS, which are cyclic vomiting, this kind of combination of other causes of vomiting like GERD and gastroparesis, diarrhea, most of which I think is probably related to irritable bowel syndrome, constipation, which is probably number 1, and then G-tubes and other feeding tubes. And then I'm going to answer some of the specific questions that I got, but I'm going to try to have some time to answer other questions that you guys have now. So as far as the current data, like I said, lots of sciencey stuff, sort of bear with me. I'd like to make this a balance of not insulting your intelligence, but also making sure that I'm filling knowledge gaps, for people who want more information. So a few years ago in 2014, there was an excellent paper that was published by Dr. Kolzan and Dr. Buxbaum, who you guys are probably familiar with. They're at pretty much all of the PMSF conferences. And they did a survey of everything that has been published so far related to PMS. In one section, they reviewed some studies that had looked at the rate of common GI problems. And it's probably somewhere between, a third to a half of our kids have been diagnosed with GERD or constipation. And my belief is that there's probably more kids than that. And keep in mind that this is compared to normal or neurotypical children, where the rate is more like 10% to 15%. And then from survey data from the PMSF conferences, if you look at the green bars over here, you can see that things like abdominal pain, stooling problems, feeding problems, toilet training problems are all very common and are a high degree of concern. And again, I'm pretty biased. Obviously, the GI tract is the most important part of the body. And so it makes sense to me that these are issues. In the PMSF Family Registry, which many of you have participated in, that Megan O'Boyle is in charge of, they have some questions about what kind of GI tests have been done. And as you can see, a third or so of people responded that their child had an upper GI scope. And then a lot of them have had swallow studies or upper GI studies. But then only a small number have had other things like colonoscopy or a pH probe or motility testing. And so now I'm going to get into there's really only two areas where basic science researchers have really looked at PMS. So one of them is zinc deficiency. So about a third of in this particular sample of kids with PMS actually had zinc deficiency. And zinc's a very important mineral for the function of the GI tract. And people that have zinc deficiency tend to have more trouble digesting things. There aren't any recommendations right now for what to do about this or to even screen kids with PMS, but I think this is something that we'll understand more as we go along. These same researchers have looked at zebrafish and not given them zinc to see what happens to their GI tract. And those that had a SHANK3 mutation were much more affected. And just in general, if you take these zebrafish, which are these little tadpole things that researchers like to use because they can study their developmental biology, and they look at different mutations in their in SHANK3, and they found that compared to those that didn't have the mutation, that all these guys, their GI tracts were about half as fast. So that it sort of makes sense, based on what we see with with all of our kids. And most of this is probably related to the way that serotonin is transmitted in all of the nerve cells in the GI tract. And just as an aside, we know that serotonin is an issue. There were a couple questions about this that were sent, but this isn't like your body is deficient for serotonin. So taking serotonin supplements doesn't fix it. It's the way that the nerves process it that is the problem. So what does all this mean? Really, in general, it means that people with PMS have abnormal communications between their brain and the GI tract. They also have abnormal function of the nerves within the GI tract. And then the third aspect that's important for PMS kids is that since 80+% of PMSers have autism or autistic features, they have some difficulty interpreting the signals that the GI tract sends. So not only do you have nerves that don't work well, but then you have less of an ability to understand the messages that they are able to send. And in general, we just don't know enough about the specific GI problems that PMS kids have and how we should treat them differently. So what I'm going to propose in going over these conditions is that we largely should treat them like we do in other kids, but I think we really need to know a lot more about this. And in that vein, you may wonder what you can do. Well, the biggest thing is that you should talk to your representatives, your elected officials, and tell them that you want more resources set aside to do research into the GI problems that face special needs kids. I'm proposing doing a study sometime in the next year where we gather a lot more detailed information about these GI problems. It would be something that would be web-based and would be a survey. And I'd like to reimburse people because I know that your time is valuable. And since you have special needs kids, you don't have very much time to spare. And then to make sure that we were adding to what we know from the registry, I'd like to make sure this information gets integrated with that. And thankfully, I have an assistant. So this is my colleague, Dr. Cecilia. This is her mad scientist outfit. She very much likes to wear masks and put things on her face. So I think she'll make an excellent collaborator. So I want to open the next poll question, which is, has your child seen a gastroenterologist who is a motility specialist? You guys are really fast. So we have about 2/3 of people responding. I'll give it a few more seconds. So we have about 80% of people. So as you can see, the majority of people have not seen a motility specialist. And as I'll get into in a little bit, I think that's important because it's a very specific type of expertise that I think can be really helpful for our kids. So the first problem I want to talk about is cyclic vomiting syndrome. So this is something mostly seen in children. And as people get older, it tends to become more of a migraine type problem. And it's very closely related to migraines. It's sort of like migraines where you have a lot of nausea and vomiting beforehand, but then that doesn't progress to a headache. So we actually have some pretty rigorous diagnostic criteria for cyclic vomiting syndrome through something called the Rome 4 criteria. Basically, what happens is that you need to have multiple episodes of just really intense, severe vomiting, where you're vomiting many times an hour to the point where the stomach is empty and there's just retching. And then this has to happen over a period of at least 6 months to meet the official diagnosis. And then it also, the criteria also say that it needs to be stereotypical, which means that it often happens at the same time, in the same way, with the same triggers. And most of the time, once it's happened a few times, parents will be able to recognize, okay, it's coming. They sort of see a look in their face, or they have a color change, or things that are unique to that particular kid. And then typically between episodes, for weeks or months, there is no vomiting. And then, of course, like with most things in medicine, you have to have no other particular explanation. And for me, this usually means that we do some kind of testing, like an upper scope or a barium swallow, that gives us a sense of, that there's not like an ulcer or GI inflammation that's causing problems. And something that I hear frequently from patients, this particular disorder is a special interest of mine, so I have a large number of patients with it. That they'll often go months or years. They'll go to the ER a dozen times in a year, and every single time the doctor says that they have the stomach flu, which happening 12 times in a year is obviously silly, but it's just not something that's on people's radar, but it is quite common. So what causes it? We don't really know, but it's probably something to do with abnormal nerve signals in something called the vagus nerve. So the vagus nerve is this big trunk of nerves that goes from your brain to pretty much every single one of your organs. And it's the main conduit that controls vomiting and nausea signals. So, if you're on a medication that gives you nausea, or you have an illness that gives you nausea, then your brain is saying something's going on. Let's go ahead and empty the stomach. But what happens with cyclic vomiting syndrome is that gets turned on and it doesn't get turned off. And then it can take, hours or sometimes days before it goes away. So what do you do if this happens? So there's two types of therapy. There's what we call abortive therapy, which is to stop an episode. And there's maintenance therapy, which is to prevent an episode. And the maintenance therapy also can prevent the severity of an episode. So it may be just as often, but it lasts an hour instead of 10 hours. So as far as stopping an episode, and my wife, who is a designer, will notice that I use colors a lot, in this presentation. So hopefully I get a thumbs up afterwards from her. Um, and the idea is that you just give lots of fluids from the beginning that an episode is, the minute that you even sense that an episode is occurring, you give lots of fluids, and ideally fluids that contain electrolytes. So things like Pedialyte, Rehydrolyte, that kind of stuff. Gatorade is okay, but it has a lot of sugar and not nearly as much electrolytes. And it's okay if they throw it up, that's all right. Some of it went down. You just keep pushing fluids. And this isn't to rehydrate them. They're probably not dehydrated yet. It's to turn off the signal. So a lot of times it helps to go into the emergency room and just get a bolus of IV fluids. But I can guarantee you that most of the time the ER doctor is going to be like, well, you're not dehydrated, so I don't need to do fluids. It's okay to tell the ER doctor that they're wrong about this. I very much advocate that you argue with your doctor about things. The way it works is all those electrolytes and fluid enter your bloodstream once they're absorbed, and it goes to the part of your brain that controls the vagus nerve, and it tells it to turn off that signal. You can also give this signal a little push by giving things like Zofran. I tend to not use things like Compazine or Phenergan because they're pretty sedating, and you don't want to be sedated when you're vomiting. And then there's some newer things that people are trying, like some of the anti-migraine medicines like sumatriptan, which is Imitrex. It's been tested some in children, and I'll use it every now and then for patients where the normal stuff that we use doesn't work very well. And then also there's preventing an episode. So one of the first things you think about is, are there individual triggers for your child? So some kids, it's long car rides. For Cecilia, her big trigger is activity, like jumping on her trampoline. We built a like a medium-sized trampoline in the playroom downstairs. And so she likes to just go in there and jump for, she would be in there for an hour or two if we let her. And several times now she'll stop the trampoline and throw up, but it's different for every kid. And then the main thing that we can use is that there are some medications that can be helpful to prevent an episode. So my favorite is something called amitriptyline. So this was an old antidepressant, decades ago, that nobody uses for anything else. It's mostly GI doctors and headache doctors that prescribe it now. And it can be sedating at higher doses, and in some very rarely in susceptible people that have something called long QT syndrome, it can cause arrhythmias. But I've been using it for many years, and the only side effect I've really seen in some people is it makes them tired. So we tend to give it at night before bed. We use really low doses, so that the risk overall is pretty minimal, but I am careful if somebody's on an SSRI like Prozac or Zoloft or medicines like that, you have to be really careful giving those medicines at the same time. So this kind of thing should absolutely only be done by a GI doctor with lots of experience with this. Some other medicines that I'll use, cyproheptadine or Periactin. It works. It's not quite as effective as amitriptyline, but it's also an appetite stimulant. So kids that aren't eating real well and have cyclic vomiting, it's something that I use frequently. Propranolol is a blood pressure medicine. I don't use that as much because it can lower your heart rate. And then a lot of people have started using some supplements, so coenzyme Q10 and L-carnitine. There's not much data on these, but I think it's probably helpful as kind of an adjunct therapy, and the risk of taking these is probably pretty low. And so here's the trampoline. This is in Cecilia's therapy center that she really likes. And again, for the modeling agents in the crowd, look at this beautiful pose. So the next thing I want to talk about, excuse me, GERD is something that is extremely common in children that have neurological disability. And gastroparesis is common as well. And they're very similar, but as I'll get into, the problem is in typically a different part of the stomach. And then functional vomiting is just kind of this catch-all diagnosis for people that have vomiting that doesn't fit into a category very well. So GERD. So everybody has some degree of reflux. And what makes it reflux disease? So GERD is gastroesophageal reflux disease. What makes that D for disease be on there is how much it happens. And it occurs because this muscle right here, the lower esophageal sphincter, which is sort of the valve that keeps things in your stomach, it's too loose. So in most people, as you get older, that muscle loosens. In children that have hypotonia, like in PMS, they have, typically from day one, they have a lot less tone. So there's, a ton more liquid that can come up. So in the case of Cecilia, she threw up on me hundreds of times. I think my wife and I had just towels in every room just because she would vomit, intermittently without any warning. And that happens, frequently in all babies, but in kids with PMS, the rate is quite a bit higher. And then a lot of kids continue to have problems as they get older. Typically, you'll have symptoms like heartburn, or you'll smell kind of an acid in their mouth. But it's actually very difficult to diagnose in kids that are nonverbal or have limited communication. So what we do is something called a pH probe. So this is a pretty nifty device. This one is called a Bravo probe, and it's this little thing about the size of a pencil eraser. So this is looking through the scope in the esophagus. And what you do is you put it on the wall with a little suction cup, and it sticks there for 2 or 3 days, and it's like radios information to a little pager that you wear. And then it gives me this little tracer like printout, and I can look and see how often is it below this red line. So this is the pH, or the amount of acid. So the lower you are, the more acid is going into the esophagus. And we have a bunch of fancy math that lets us determine, is this a normal amount of reflux, or is this in the category of making it a disease? I will be honest though, if people are telling me about symptoms that are pretty characteristic, like heartburn or things like that, or what we call acid brash, where there's like a sour taste or smell in the mouth, I tend to just treat without necessarily doing this. But I think it's something you got to consider if your child has some communication difficulties. And this just falls off after a few days and you poop it out. So how do you treat GERD? So really, the vast majority of people should be on what are called PPIs. So that's anything ending in prazole, like omeprazole, lansoprazole. The brand names are things like Prilosec and Prevacid and Nexium. And there's about 9 or 10 of them now. They all work pretty much the same. And despite the fact that all of our published guidelines for more than a decade have said this is the best medicine, and that there's hundreds of research articles that prove this, lots of people still like to use other medicines. But if you really want to effectively treat GERD, this is the stuff to use. They're generally safe long term. I've never really seen any side effects from them. I like to avoid them in babies less than 6 months because you really need that acid barrier. You have about a triple your risk of pneumonia or stomach flu if you take these medicines at this age. And then there's some recent data that elderly people with heart or kidney disease, that these things can be made worse if you're on PPIs for decades at a time. The older medicines are called H2 blockers, or histamine 2 receptor antagonists. This is why we have to have abbreviations for stuff in medicine. Makes us sound smart. So the two examples for this are ranitidine and famotidine, which are Zantac and Pepcid. They work, in a similar way, but they aren't quite as effective. And then one of the big issues is that you can become resistant to them over time. People will often use things like antacids, like Tums, but these just work, really for 30 minutes or so, and they're just a short-term solution. Sucralfate, people like to use a lot, but there's actually really no evidence that it helps with acid reflux. And then, as with everything, there's a big impact by lifestyle and diet changes. Don't lay down after you eat. Don't eat a lot of rich foods and things like that. And I'll get into some of that stuff in a second. All right, so the next vomiting disorder is something called gastroparesis. or gastroparesis. And the gastro means stomach, and the paresis means nerves don't work. And so it has lots of causes. Sometimes older diabetics can get it. Sometimes it happens after you get a virus. But in PMS kids, it happens because, like I talked about, the nerves don't function well and they're slower than they should be. So in this case, the way that the muscles push things out of the stomach is delayed. And so you end up that your stomach's full of food or liquid and it doesn't empty fast enough. So then you'll often have vomiting of food or formula hours after you eat. So this is something to look for if your kid throws up breakfast in the middle of the night. The way that we diagnose it is something called a gastric emptying study, where you do a meal of eggs, and it's fairly gross. I have a lot of patients that will just throw it up because it smells funny and isn't something you would eat normally. But basically, the radiologist mixes up some radio tracer with some like liquid egg substitute, throws it in the microwave, makes it like some scrambled eggs, and you eat a bowl of it. And then the X-ray watches how fast it leaves the stomach. And we have a bunch of standard values for how much should leave the stomach. If this kind of thing is ordered, you always want to make sure it's a solid phase study. The liquid doesn't really give you much information, and then you're just exposing your child to radiation without getting any information. So how do you treat gastroparesis? So erythromycin is the first line. It's pretty safe. It's an old antibiotic that just stimulates the nerves in the stomach to start moving faster. Another one that's used frequently is called Reglan. I don't use this medicine, and I really don't recommend that people do. There is a pretty high rate of neurological side effects. Sometimes these can be irreversible, and it's mostly dystonia or abnormal facial movements, abnormal arm and leg movements, and it really is not more effective than erythromycin. It also often helps to do one of the reflux medicines at the same time. It helps what's called gastric compliance or just stretchiness. It helps to be on a low-fat diet because the more fat you have in your stomach, the slower it is. And it helps to have like less frequent meals and make them smaller. But to be perfectly honest, there's nothing that works super well. And a lot of people end up having to focus a lot on this, where they eat like multiple snacks throughout the day so that the stomach has time to empty it. And then functional vomiting is just sort of this catch-all for people that vomit all the time that don't fall into one of these categories. It's probably more difficult to treat because we don't understand it as well. I tend to use the same kind of medicines that we use for cyclic vomiting. And again, this is all stuff that should really be done under the auspices of a pediatric or adult gastroenterologist. So this is one of my favorite pictures of Cecilia. So this is after she learned how to dive out of her pack and play and went face first into the floor, and appears not to be bothered by it, which is sort of interesting because we talk a lot about how our kids have a much higher pain tolerance than they should. I think our other kids would have still been crying from this, but she's pretty tough. So she's definitely my hero. So I'm going to do the next one, which is, and this is a very common problem, which is how long does it take to get in to see a gastroenterologist? For those of you that answered yes, that you have seen one, how long did it take? And all right, we're getting close to half of everybody voting. So, this is a big issue for me because I really don't feel like people should be waiting a really long time to see a gastroenterologist or to see any specialist. And this is one of the main system problems that we need to fix. And as you can see, there's well over half of people are waiting longer than a month. This is a little better than I thought it would be. And this, by the way, this varies quite a bit from one part of the country to the next. So the next problem that I'll talk about is diarrhea. And so most kids with PMS, and this is not like infectious diarrhea. That's a different problem. Those are easy to test for. It's not usually too hard to get your primary care doctor to test for these. What I'm talking about is the more chronic diarrhea. And Most people fall into a disorder called irritable bowel syndrome. And what this is an issue where the nerves in the colon either go too fast or too slow, or as is true in most people, both. And this can often result in alternating episodes of constipation and diarrhea. We have a variant of this in younger kids that we call toddler's diarrhea. It's mostly based on drinking too much juice. It tends to get better if people decrease the amount of sugar that they're taking in. There's no test to diagnose this. There are some medications that can help, but in general, they aren't groundbreaking. We have some things called Levsin and Bentyl, which are antispasmodics, which decrease the amount of contractions of the nerves in the colon. And there's some newer medications like Viberzi, which I misspelled, that are not approved in children, and it's very difficult to get them approved via insurance, and they can sometimes cost thousands of dollars. So really, for this kind of stuff, diet is the biggest factor. And so, it would be a whole lecture just going through the different diets that exist, and there's a vast number of them. But really, the main take-home point is that most of them involve eliminating excessive carbohydrates. So the one that I recommend most often, really the two that I feel have the most medical evidence, are the low FODMAP diet and the specific carbohydrate diet. So the low FODMAP diet is avoiding a lot of sugars that are based on fructose. And so it's a lot of stuff that's in fruits and some vegetables and a lot of grains. And the thing I always tell families is carrots good, apples bad. And the apples part really flies in the face of the old saying that an apple a day keeps the doctor away. That is definitely not true for GI doctors. But the important thing here is that things that we traditionally think of as being healthy, that are healthy, may actually make diarrhea worse in somebody who's susceptible. The specific carbohydrate diet is a variant of this, where you avoid most sugars in general, most grains, and a lot of the lactose-containing dairy, like cow's milk. And then a variant of this that has been kind of more marketed is something called the gut and psychology syndrome, or GAPS diet. And the idea of this is that all of our problems are because of our gut and our diet, and that if we just go on this diet, that everything will be better. But it is just another variation of the specific carbohydrate diet. And in this case, they also recommend avoiding pasteurized dairy and a lot of other starchy vegetables. The gluten-free diet is very common, but it tends to work, it's because you're avoiding a lot of excessive carbohydrate diets. And then there's a very specific thing called the Nemechek protocol, which is very well known in the autism community, where basically it is a variant of some of these other diets that adds in inulin, which is a really common starch that's found in a lot of vegetables. And then DHA, which is a docosahexaenoic acid. There'll be a quiz on that later, which is a essential fatty acid, and then olive oil. And the thing to remember is that all of these are mostly just avoiding excessive carbs. Any doctor will tell you eating too much sugar and eating too many carbohydrates is bad for you, but especially in the setting of somebody that has chronic diarrhea. And in a lot of cases, really reducing sugar intake can eliminate symptoms. The other thing to be careful about is that there's just so many of these diets, and a lot of them are being sold to you. So somebody will have a website or a business that said, well, all of your problems and all of your symptoms are because of your diet. If you just do this diet, which by the way costs $100, then all of your problems will be cured. It's the same thing as a pharmaceutical company trying to sell you a medicine. So you need to approach these things with healthy skepticism. And honestly, from my point of view, I have no skin in the game. I don't get paid any different based on what I recommend. My only goal is to see the patient in the office the next time and that they've taken a step in the right direction. So just, keep in mind that there's not a lot of scientific evidence that many of these work beyond just sugar and carbohydrate avoidance. But there's very little harm in trying any of these. There's really almost zero risk in doing it. So if it's something you want to try, I think I would fully support that. So here is Silas and Cecilia not adhering to the specific carbohydrate diet, or any of them actually, at the local froyo place. And this is him being sweet, Silas being sweet for once. He's starting to get more annoyed at how much his sister worships him. So constipation is probably the big one. I think that's what, I've talked to probably 100 plus Phelan McDermid syndrome patients, and I have 7 or 8 that I see in my practice. Excuse me. And this is by far the most common GI problem that people report. And it happens in PMS for 2 reasons. So the first is that, as we talked about, the enteric nervous system, or that nervous system of the gut, has less tone and less coordinated movement in our kids. And there's a wide spectrum across which that occurs. But also, our kids are also, whenever they're interpreting these signals, they have less ability to do so. So their ability to use those muscles that you poop with are not as good. So the result is poop spends too long in the colon, poop gets too dry, because that's what the colon does, is dry out poop, and then you result in constipation. So how do you fix it? Well, stool softeners are probably the most important thing. That's always what I start with. Most people that have constipation need to be on some kind of stool softener. There's a bunch of different ones: Miralax, lactulose, mineral oil, to name a few. They're generally safe, pretty easy to titrate, which means to adjust the dose. They don't affect the GI nerves. They just make it easier to poop. And they work better if you give them consistently, so that you always have soft poop. They also work better if you start out with a completely clean colon. So I'll often recommend that patients do a clean out before they start. And then it just is much easier to make sure that you're consistent whenever you start with a clean slate. I usually give a half a cap to a cap full of Miralax every day, and then tell the parents to just adjust the dose up or down so that you have a soft stool every day. The other category is stimulant laxatives. This is stuff like Senna and X-Lax, magnesium citrate, Dulcolax, and there's a bunch of them. And they work differently. They actually interact with the nerves in the colon and give a little extra push. And I usually use these as a second step if the stool softeners aren't really working on their own. You can become dependent on these. You can't become dependent on the stool softeners, but you can on the stimulant laxatives. And I have a lot of patients that report more pain with these because it's actually causing a cramp in your colon on purpose. But overall, they're pretty safe and pretty well tolerated. And then everybody's favorite, this is where most of the poop jokes and puns come in, is the rectal medications. So you got enemas like Fleet's enemas, suppositories, and they just kind of help relax those inner anal muscles so that a bowel movement can proceed. And then in the case of enemas, they liquefy the poop. And I think something happens to you when you talk about poop for a long enough time, where you just don't think it's gross anymore. And I'm sure that happens to all of you, especially if you have constipated kids, where you've like somebody remarked on the Facebook group the other day that that your kid has Phelan McDermid syndrome when you get poop on your hand and you don't even notice it. Some of these are also stimulants. So like Dulcolax has kind of both effects of being a stimulant and also a suppository. And it can be kind of more helpful in kids that have weak pelvic floor muscles, like PMSers with low tone, and to sort of help them initiate that bowel movement. A word of caution about enemas, though: they can be dangerous in younger children because you have to pass that liquid out, or the phosphate can be absorbed, which can be dangerous. But for most people, you put the enema in, and then it comes out pretty soon afterwards, like a few minutes afterwards. Uh, there were a few questions about the overlap between constipation and urinary symptoms. And so the thing you got to remember is that all these muscles, so this is looking down the abdomen at the floor of the pelvis. So this is the back, and then this is the front up here, by the pubic crest. And the bladder sits on top of this right next to the rectum. And so whenever your muscles don't work well to help relax, to have a bowel movement, they often also don't relax to help you pass urine. And so a lot of children that have constipation can have urinary retention as well. So one of the things that we have to help with this is something called a motility study. So this is a special kind of colonoscopy where we pass the colonoscope all the way around the colon, and then we thread a little pressure sensor all the way around. And then we can measure what level of contraction there is at different parts of the colon, and you can get a sense of, is there a section that's not working right? Does it work right, but the whole thing is slow? And then that lets you decide, are you a candidate for like a surgical procedure? And the thing that we do most often is something called a MACE, or an appendicostomy, or a cecostomy. And I apologize for the gross pictures. But MACE stands for Malone Antegrade Continence Enema. And all of these things are antegrade enemas, which means that you're basically putting an enema in the front of the colon rather than at the end. So then it tends to be more effective. And what you end up with after the operation is this tube, typically that comes out of the belly, like near the belly button, that you can then flush with Miralax or water, or whatever you need. And in general, this is just some scores for these different things before cecostomy and after cecostomy. These are in children that the paper quoted as being neurologically intact, end quote, not necessarily in PMS. But the principle would be the same for a PMS kid. And there's many of your kids have MACEs. And in general, you have a pretty significant improvement in bowel movement frequency, accidents, pain, medications you have to use, and so forth. So it can be kind of a scary thing, but I think as long as you're being precise about it and getting a thorough motility evaluation beforehand, then you maximize your chance of it being successful. And you want to do this somewhere where they do lots of them. There's probably 15 or 20 places in the country, in the United States, where they just do a high volume of these things. And I honestly think it's worth traveling to get a motility evaluation and to get a surgery like this done, where they know exactly what they're doing. Another item that came up a lot on questions was this idea of small intestinal bacterial overgrowth, or SIBO. And what happens here is that, so most of your bacteria are in your large intestine. So this is greater than 10 billion bacteria in 1 ml of fluid, compared to less than 10,000 bacteria in 1 ml in your small intestine. So if your intestine is slow and things don't move through quickly, then these bacteria like to swim upstream and start becoming more prevalent in the small intestine. And when that happens, you get a lot of bloating and air production that comes from having all these excessive bacteria. And typically we treat it with some specific types of antibiotics like metronidazole or Flagyl or rifaximin. But again, this is something that is not easy to diagnose and requires some specialized testing like breath testing, and it requires someone who's seen it before and knows how to treat it. In extreme situations, if the colon is really not behaving, we can do what's called a diverting ileostomy, where we actually bypass the colon. And a lot of patients. It's a big step, but I've had a lot of patients that have done this. None with PMS specifically, where their quality of life is just amazingly greater. And then also in rare situations, we'll do a period of just GI rest, where we put a central line in and do TPN, or total parenteral nutrition, which is just 100% IV nutrition. And these have risks, obviously. This is not a minor surgery, and having a central line in gives you a risk of a bloodstream infection just by having it. So, I mean, these are really for extreme situations where nothing else is working, and the patient's quality of life is being really affected. And there's something else to consider, I think, that a lot of PMS parents talk about, is that our kids have decreased pain sensitivity. So what do you do when you have a kid that is upset, um, and it's hard to tell where it's coming from, but it sure seems like it's coming from the GI tract? I think there is not an easy solution to this problem. It can be very difficult to figure out if apparent pain or behavior are coming from the GI tract. But this kind of problem can be very common in PMS and other problems like autism in general, where there's altered sensory processing. And I think you have to rely on parents' intuition quite a bit. And be prepared to be dismissed by your healthcare professionals that it's not from the GI tract, but you have to, quote, go with your gut. Um, I've made that joke at least 1,000 times at this point. And really, the thing I'd suggest in this situation, if you really feel like your child is having a lot of pain coming from the GI tract, and you're not really getting anywhere, I think really seeing a motility specialist and considering more advanced motility testing would be a good idea in this case. And here's again another modeling shot. So this is the blanket that she got whenever she was in the hospital. So she's feeling much better now after her RSV infection. So the last thing I want to talk about is G tubes and feeding tubes. So whenever you get these, you don't get them because you have a GI problem. Typically, you get it because you have a swallowing problem. So you can't take you can't get the food into your stomach through your mouth. So we have to bypass that and go through the wall of the stomach. It's a pretty minor procedure. I do usually recommend having this done by a pediatric surgeon. I used to put them in myself, but for the past few years, I've stopped doing it because I feel like if there's a problem or it becomes a more complicated situation, the pediatric surgeon can always convert it to a more open surgical situation. And also they just do a lot more of them. So definitely do it in that kind of situation would be my advice. And then in some people, typically those that already have a G tube where the stomach is not emptying very well, like if they've got feeding problems plus gastroparesis, we will put in what's called a GJ tube, where we change the tube out and it actually goes all the way around so that it's well into your small intestine. And that's, again, that's a big step, but it's necessary in some cases. And you typically have to use a specific type of formula. There are lots of them. The first thing you always have to do if you're going to be on any kind of formula is talk to a registered dietitian. They're licensed to do this kind of stuff. They are, across the board, very knowledgeable, and most of them have a ton of experience with children that are fed through G tubes. And really, it breaks down into 4 different types, and there's not really anything within each type that's better than another. You have standard formulas like Pediasure, hypoallergenic formulas that have had the protein slightly broken down, and elemental formulas where the protein is completely broken down, and then more recently, blended formulas, which are basically where people just get food and put them into a blender and then put it into the formula bag. And I'm a little surprised that I think until I was a doctor, I just pretty much assumed this is how they made regular formula. But so it's kind of surprising that we kind of needed to go back to this. And there's a bunch of brands for this, and the formula companies have kind of gotten into this late in the party. Complete is Nestle's and Harvest is Mead Johnson's, and so expect that as they make contracts with insurance companies that you're not going to have as many choices as you used to have for blended formulas. And if you're a really, really devoted parent and you have way too much free time, then you can blend the formulas yourself. but they're largely similar. And a lot of the benefits, like the increased amounts of fiber that you get with blended formulas, are going to be the same with both of these, with a lot less work. A lot of times, whenever people get G tubes, they get what's called a Nissen fundoplication, which is where you wrap the top part of the stomach around the bottom of the esophagus so that stuff can't escape. This used to be done a lot more in the past, and I think most of us don't recommend this anymore because you tend to have problems later. It gets too tight or too loose, or doesn't completely function as intended. And it doesn't really prevent a lot of the stuff that that people are worried about. And so I have some other general suggestions that I'll run through real fast, and then I have some answers to questions that were already in, and then I'd be happy to take some questions from you guys. So avoid antibiotics if you can. That just messes up your GI flora. Avoid overuse of procedures and tests and CT scans. Doing a scope honestly does not usually result in a change in your diagnosis in PMS. So make sure that there's a good reason for doing it before you go through with it. Avoid going to the ER if you can. Diet plays a relatively minor role in all of this, with the exception of diarrhea. But there's very little risk. But don't put all your eggs in this basket. It's important to typically do multiple things to have some improvement. And I certainly don't want to have a whole talk about this, but I just want to urge you absolutely to vaccinate your children against preventable serious problems like rotavirus and hepatitis. I've seen children die of these. And you can read all the science and look at all the graphs that you want, but the one piece of information I want to leave you with for that is that I know a lot of pediatric specialists and a lot of researchers, and most of them have children, and all of those people vaccinate their children according to the CDC recommendations. There's no conspiracy. It's just by far the smartest thing to do to protect your children, especially if they're vulnerable. There's lots of practitioners that will offer you cures in the forms of diets or supplements. Just know that if something sounds too good to be true, it probably is. These are hard problems. Remember that our children are unique, and that not all doctors are aware. In fact, very few doctors are aware of Phelan-McDermid syndrome. And so I think it's partly our job to educate them. Not all doctors are good. Just because they're at a good hospital or they're nice, that doesn't mean they know what they're doing. So be aggressive about finding the right team. If you're not getting along with the doctor, find a different one. Like, their feelings are a lot less important than your child's health. And then finally, that everything is a balance, that everything has some risk and some benefit, and you get to decide what's right for your child. And so this is Cecilia catching some rain. And then the last poll question that I wanted to give you guys was, how familiar do you think your doctors are, either your primary care doctor or your gastroenterologist, with Phelan-McDermid syndrome? And I'll run through some of the questions that were already sent in that I didn't answer specifically with the talk next.
Great, thank you. And then we do have a couple that came in, so we can go through those once you're ready.
Excellent. So as you can see, and this is unsurprising, it's pretty unusual for your doctors to be familiar with Phelan-McDermid syndrome, and this is something that we absolutely hope to change. So some questions that I got that really didn't fit into a category were, so one of them was, is there overlap between psychological and behavioral problems and GI problems? Absolutely. All of the nervous system is connected, and it goes both ways. If you have worse GI problems, it can absolutely make psychological and behavioral problems worse, and vice versa. So I think it's important to approach psychological and behavioral care with that in mind. Should I request an upper scope or a colonoscopy from my child's GI doctor? Potentially, but it is honestly not usually helpful for PMS. But I think it's something you have to be thoughtful about. And if somebody recommends it, you really want to know why they're recommending it and what specifically they're looking for. So what are some urgent GI symptoms, like where you should, go to the ER? I would say vomiting that doesn't stop, really bad abdominal distension, diarrhea or vomiting causing dehydration, are all things where you should go to the ER. And then there's a few other things that I think usually mean you need to see a GI doctor sooner rather than later. Things like, do you have bleeding? Like, is there blood when the child throws up, or in the stool? Is there weight loss or lack of growth, or is there trouble swallowing? All of these things I think need to be addressed sooner rather than later. So how can we better diagnose GI problems in PMS? And unfortunately, there's no good answer. I would suggest seeing a pediatric gastroenterologist or an adult gastroenterologist for those that have adult children that has experience with special needs patients. There are just unique things that they have to understand and an approach that they have to take that, I think a lot of doctors don't take just based on their experience. Motility experts are hard to find, but I think that's, they can often be helpful, with GI problems in these patients. What about iron deficiency? It's not anything specific to PMS that we know of, but it's not been well studied. In general, iron deficiency is caused by either not enough iron in your diet, which is probably the most common reason for PMS kids, but also can be caused by having bowel inflammation or situations where you're not absorbing the iron, like if you have chronic diarrhea. But it's not something that I think you necessarily need to routinely check simply because of the PMS. I would base it on, if they're growing well and have normal intake of calories, then the odds that they're significantly iron deficient is pretty low. The sodium supplementation help the GI tract. I actually have heard about this a lot recently, and people have been pushing the idea that GI problems are because you don't have enough sodium. The sodium doesn't specifically affect your GI tract. It gets absorbed by your GI tract. So if you have a lot of diarrhea, you can have low sodium. But I mean, everywhere in your body needs sodium, and your kidneys regulate it. Every cell needs sodium. So I would say sort of yes, it helps to make sure that there's plenty of sodium in the diet, but it's not going to specifically treat any particular GI problem. Are food allergies common? Probably not more common than most kids, but we don't really know for sure. What I think really are more common are food sensitivities. But and that's something where you'd have to basically try a diet or try a food and see the impact that it has on your GI tract. There's not a good way to actually test for sensitivities. Lots of people claim they can with blood tests or poop tests, but for the most part, that's not based on science or reality. There are some rare types of food allergies where it affects your GI tract and causes inflammation, and the only way to know if that's there is to look with a scope, although that's relatively uncommon. If you're gagging or your child's having trouble gagging or eating at certain times, most of the time that's more of a hyperactive gag reflex, and it's certainly more common in kids that have abnormal nerves in the GI tract. A lot of kids with cyclic vomiting and that sort of stuff, they have a really hyperactive vomiting response, so they'll gag with eating and then throw everything up. Mostly the problem here is usually something that a speech therapist can help with, and there's not much you can do from the GI tract point of view. Occasionally, some kids will have what's called eosinophilic esophagitis, which is one of the GI food allergies that can occur in your esophagus, and that's often something that we go to if kids have swallowing problems that don't get better. Are gastric or intestinal ulcers common in PMS? They're common in people in general. I would not say they're probably more common in PMS. Usually now they're caused by either H. pylori, which is a bacteria, or NSAIDs like ibuprofen. A lot of times people get diagnosed with ulcers because somebody just said they had ulcers because their belly hurt. But the only way to know for sure if there are ulcers is to look with a scope. So this would be one of the reasons that a GI doctor would look, is to go, I want to find out if there's an ulcer present. Um, uh, Probiotics. This is a favorite topic of mine. My previous job in St. Louis, we were involved in the project that was describing how babies establish the bacterial population in their intestine. And I think probiotics are probably safe in most situations. There's a lot of things they can help with, especially things like diarrhea, sometimes adults with chronic constipation. But really, they're better as like an adjunct, as an extra treatment for something. It's unlikely that they're going to cure any one thing by themselves. Um, and one thing that we found with this, study from St. Louis was that the variation from one person to the next is massive. And what probably matters is that you have a lot of diversity of the bacteria in your GI tract. So, really avoiding antibiotics is the main way to do that. So don't take antibiotics unless you absolutely need them. Most respiratory infections don't need antibiotics, and so forth. Can Miralax have non-GI side effects or toxicity? And we talked about this for a little bit at the conference over the summer, but almost certainly not. There have been multiple studies looking at, are there any breakdown products that the body absorbs, but it looks like Miralax just stays in your GI tract. I've been giving Miralax, I've been practicing for almost 15 years, and I've never seen Miralax cause any problem other than making you poop too much. And then the last question on here was, can constipation or vomiting or bowel obstruction develop years after surgery? I would say absolutely yes. So, it's always something to consider. If your child has had surgery in the past, they are at risk for adhesions, which is scar tissue inside your abdomen. So, always make sure that's considered. And you often, need x-rays or things like that to help figure it out. But it's just something to make sure that whoever's taking care of your child knows that, oh, hey, they had their gallbladder out, or they had an appendectomy in the past. And then Ghost Cecilia, thanks you very much for your time. So Jackie, I just go to the questions panel here.
Yeah, I have them
right?
up if you want me to go through them for you.
Yeah, would you mind?
Yeah,
There's a lot of them.
yeah, there are a lot of them, and some of them kind of repeat a little. So
Okay.
the first one we have is, we give our 18-year-old daughter a suppository every morning. In addition, we do an enema at least once a month. Always shocked how much comes out, even though she has 1 to 2 bowel movements per day. Do you think this is an appropriate routine to prevent constipation?
I think the answer to that question is, does she have regular bowel movements and is she comfortable? And as long as you found a regimen that works for you, that doesn't cause her any problems, that's consistent, then that's the right regimen. Doing an enema every now and then, or doing suppositories, or doing all these things is not going to hurt her. So a lot of people, it just takes some time to find the regimen that works for them. So I would say, I would say absolutely. I think this is a good regimen.
Great. Okay, next question. And I am not a clinician, so sorry if I mispronounce this. If your kiddo had a Nissen fundo, would this affect how we would be able to assess this? I'm not sure what this is referring to, but maybe if you could just talk in general about if that surgery would affect how you would assess GI issues.
Yes. So I touched briefly on the Nissen fundoplication, and it's what's called an anti-reflux surgery, where you increase the tone of that lower esophageal sphincter muscle by wrapping part of the stomach around it, and it works very well at doing that. But the problem is that you lose the ability to vomit. So then your stomach wants to release air and it can't. And then a lot of kids, especially if they're eating by mouth, it impairs their ability to swallow. And additionally, if you get it when you're younger, the rest of your body grows, then it can become either too tight or too loose. And so in general, I recommend against them, but it shouldn't prevent you, to sort of answer the question, I guess, it shouldn't prevent you from being able to assess problems. You can still get a scope in there. You can still look around. You can still do pH probe studies. It doesn't change how the stomach works fundamentally. It just makes that top part of the stomach tighter.
Great, thank you. This one actually came in via email last night. My son is an adult and moves his bowels typically every other day. The bowel movement is typically very large. I'm concerned that it's too large, maybe constipation, but have been told that since he moves his bowels every day, or at the worst, every other day, it isn't constipation. He was completely toilet trained and now needs prompting to use the toilet, typically begins to lower himself and bounces back up before using the toilet. Comments on that?
This is a good question. So the end result is what's important. And in his case, you want him to have a bowel movement and I usually say anywhere between twice a day to every other day is fine. And so that part is taken care of. But then, you also want him to use the toilet comfortably. And so most of the time when you're having, larger bowel movements like that, you often need to make the poop softer. And, and that's a situation where I tend to say, let's use more Miralax or more mineral oil, or potentially add on like a stimulant laxative to try and get him to go more often. But nothing's going to happen to him. He's going to be fine. If he poops like that for the rest of his life, it's not going to compromise his health or his life. As long as you're going regularly, then you're not going to, have some serious problem most of the time. But I think our goal needs to not just be regular bowel movements. It needs to be that plus, the child being comfortable and being able to use the toilet on their own, because that's a big part of empowering, being self-sufficient and stuff like that. So, so short answer, yes and no.
Great. So I noticed also a number of other questions have come in. So there's a lot. Let's take a couple more. I want to respect your time, and I can always send you the questions afterwards, and we can kind of follow up with people. Does that sound okay?
Yeah, and Sue, was it you or Sue that mentioned maybe doing even like a repeat like Q&A type session to help answer some of the questions?
Certainly, yes, we can talk about that. I know this is a popular topic.
Okay, yeah, let's go ahead and do a couple more.
Okay, so does Botox at the pylorus work? We tried it twice, 6 months apart, and the first time it worked immediately, and the second time it had no effect.
So Botox is a medication that paralyzes muscles. That's why people use it on their face, is because it makes everything kind of smooth out. And it works, we use it in the GI tract pretty frequently to help a muscle relax. So you use Botox in the pylorus, which is the exit to the stomach, to get the pylorus to relax, typically in situations where you have spasm of the pylorus. It lasts anywhere from 3 to 6 months typically. And so, whenever you do it, if it works, you'll often go in and try it again. My experience is that it's kind of hit or miss. It isn't really easy to figure out which people will respond to it. Typically you look in there with a scope, and if you see the pylorus just squeezing really tight and contracted, then you inject it with Botox and then watch it relax and then hope that solves the problem. But typically, especially kids with underlying neurological problems, it's sort of it isn't a constant thing. It's sort of up and down. There isn't a ton of risk to it. It's, anytime you do Botox, there's a risk that it could get into your bloodstream and cause, the respiratory muscles to be paralyzed, but that's, very, very small. But I would say that's been my experience with it, is that we tried initially, it seems to help, but then with repeat administrations, it doesn't work quite as well. But this has not been well studied in children and not at all, to my knowledge, in PMS.
Great. Is Prilosec okay for PMS kids with a singular kidney?
Oh, good question. So there's been a lot of talk recently about, so Prilosec is one of the proton pump inhibitors, or PPIs. Um, and there's been a lot of talk recently about the fact that in elderly patients who have been on these PPIs, typically for a decade or more, there is about a 20%, like it isn't a huge amount, but a 20% higher risk for chronic kidney disease. Um, we don't know if there's really any change in that kind of risk in children, but my interpretation of all this research is that it's sort of unclear that there's an obvious risk, because a lot of the people that have reflux, especially the elderly, also have other medical problems, so they would be more likely to be on a reflux medicine. And it's really hard to tease out if it's really causing kidney problems. I mean, it's something I would discuss with your child's nephrologist. But in general, I advise people that the risk of kidney damage or the risk of heart disease long term, especially in children, is probably still very low.
All right, let's take two more, and then we'll get the rest to you separately. Are scheduled
That sounds good.
enemas, Pedialyte, glycerin, several times a week safe instead of stool softeners?
Absolutely. So glycerin is completely safe. So glycerin is just the slippery part of soap. So it doesn't get absorbed in the body. It just helps lubricate the anal canal so that stuff comes out easier and stimulate that inner anal muscle to relax. You could give it you could give it every day. You could give it multiple times a day, and I really don't see it causing any problems. And a lot of my patients that have like neurologic problems and constipation, that's something that works really well for them, because that, like I talked about a little while ago, the muscles in the floor of the pelvis don't have a lot of tone. So then, the child has a harder time relaxing those muscles. Um, and what the glycerin does is just help stimulate those muscles to relax and start the whole bowel movement process. But I don't, there's not really medication in there besides making stuff slippery. So I would say short answer to that question, no, it's not something I would worry about long term.
Okay, and the last question for today. As parents, after listening to this, can we add a stimulant regimen as a trial without seeing a GI motility specialist?
Yeah, I think that's fine. I mean, it tends to be the stimulant laxatives are often prescription, but in some places you can get stuff that has senna in it over the counter without any problem. Um, I would say that the risk of doing that is pretty low. And often it's just you want to make sure you have a stool softener first, because you don't want to be trying to stimulate the colon to push a hard ball of stool. You want it to stimulate pushing something soft. But I don't see any problem with that, with just adding a stimulant laxative. Lots of pediatricians and primary care doctors feel comfortable doing that too. So again, I'm biased, and I think all of the PMS kids should see GI doctors. Or everybody can just move to Indiana. That would make it much more convenient for me. I think that's something pretty safe and straightforward that the primary care doctor should be able to handle pretty easily.
Billy, thank you so much for your time and your presentation. I know this has been super valuable to all of our families. And thank you all for joining. Have a great rest of the week.
Thank you guys very much.